Welcome back to The Explainer. Look, today we're stepping right into the high-stakes world of medical surgical nursing. This is basically your ultimate, exam-focused crash course on how to recognize and manage some of the absolute most critical diseases you're going to encounter on the floor. And of course, on your nursing cadre DPE exams. We're talking about the golden window. That incredibly brief, crucial time frame where your ability to instantly recognize what's going wrong and immediately intervene literally makes the difference between a patient bouncing back or rapidly deteriorating. So, let's get right to work.
All right, here's our game plan. We're going to cover metabolic crises, looking closely at diabetes mellitus, then cardiac emergencies, specifically myocardial infarction. After that, we'll get into systemic collapse and managing shock, and we'll wrap it all up with your essential nursing exam takeaways.
Section 1. Metabolic crises. Diabetes mellitus.
Let's break down the underlying patho. In type 1 diabetes, you're looking at an absolute insulin deficiency. The beta cells of the pancreas are just completely destroyed, usually by an autoimmune trigger, which means basically zero insulin is being produced. And because of that lack of insulin, the body is forced into this massive state of lipolysis and protein catabolism just to survive. Now, flip over to type 2 diabetes. Insulin is actually there, it's present, but the body cells have built up an insulin resistance. It's like the lock just isn't recognizing the key anymore. That's a vital distinction for your exams. Type 1 is an absolute deficiency, while type 2 is all about resistance and varying degrees of secretory defects.
Now, this is a massive high-yield differentiator you need to know cold, contrasting DKA and HHNS. DKA almost always happens in type 1 patients, and it hits incredibly fast, usually accompanied by hyperventilation. The real defining features here are metabolic acidosis and positive serum ketones. That's what gives the patient that classic fruity acetone breath odor. On the flip side, HHNS is way more common in type 2, and it sneaks up on you gradually. You are going to see massive sky-high blood glucose levels and terribly elevated serum osmolality. But the critical difference? There's no acidosis, and serum ketones are negative.
Okay, so how do we actually manage this on the floor? First off, you've got to be ready to act fast. That means giving rapidly absorbed carbohydrates if they tank into hypoglycemia, or jumping in with IV fluids and insulin replacement if they're in a hyperglycemic crisis. Meticulous skincare is totally non-negotiable, especially for the feet and legs. Any cuts or blisters have to be treated immediately. You're constantly checking vitals, strictly monitoring intake and output, and getting daily weights to track their fluid balance. And honestly, above all else, you have to watch them like a hawk for acute complications. If your patient suddenly shows altered thinking, pallor, or goes into a seizure, that golden window is slamming shut. An unconscious hypoglycemic patient needs IV dextrose or glucagon instantly.
Section 2. Cardiac emergencies, myocardial infarction.
Think about this clinical presentation for a second. Persistent, crushing substernal pain or pressure. A feeling of impending doom. That right there is your wake-up call. It's the cardinal, absolute hallmark presentation of an active MI. Now, that pain might radiate down the left arm, up into the jaw, the neck, or even right between the shoulder blades. But keep in mind, in elderly patients or folks with neuropathy from diabetes, this classic crushing pain might actually be completely missing, or just feel like mild heartburn. Sudden, intense anxiety, sweating buckets, and unexplained shortness of breath are huge red flags. They demand your immediate reaction. So, what's our action plan? First, you thoroughly assess and document the exact severity, location, and duration of that pain. Second, you get an ECG immediately while they're having the chest pain to catch any ischemic changes in real time. Third, and I can't stress this enough, always check their blood pressure before and after giving nitroglycerin. If you don't, you risk bottoming out their pressure and causing a catastrophic hypotensive event. Fourth, administer IV morphine and supplemental oxygen as ordered. That's going to decrease the heart's workload and help manage that severe pain. And finally, get them on continuous cardiac monitoring so you can catch any lethal arrhythmias the second they start.
Section 3. Systemic collapse, managing shock. You absolutely have to have these three main types of shock locked down. Notice how fundamentally different their root causes and treatments are. Cardiogenic shock is a pure pump failure, often caused by the MI we were just talking about. The left ventricle dysfunctions and cardiac output just drops off a cliff. Assessment-wise, you're going to see pale, clammy skin and severe oliguria, like less than 20 milliliters of urine an hour. Treatment, intra-aortic balloon pump and vasopressors. Then you've got hypovolemic shock. That's a loss of intravascular volume, usually from massive bleeding. You'll feel a rapid, incredibly thready pulse, and you treat it with aggressive fluid and blood replacement. Finally, septic shock is triggered by a massive systemic infection. The treatment focuses on finding the source, pulling infected catheters, and hitting them hard with antimicrobials.
I really want to pause and emphasize this clinical alert for cardiogenic shock. Monitor the patient closely when using vasoactive drugs to maintain the balance between adequate perfusion pressure and reduced afterload. This is where razor-sharp nursing comes in. You're walking a very fine tightrope here. You need enough pressure to keep perfusing the vital organs, for sure. But if the afterload gets pushed too high, that already weakened left ventricle is just going to fail completely. Any hemodynamic decline has got to be reported immediately.
Now let's talk about how sneaky septic shock can be. In the early hyperdynamic or warm phase, the patient might actually look okay. Their skin could be pink and flushed, and they actually have an increased cardiac output because the body is trying so hard to compensate for all that peripheral vasodilation. It can totally fool you. But if you miss it, they will rapidly slide into the hypodynamic or cold phase. That's when the skin goes pale and cold, the cardiac output plummets, and multiple organ dysfunction syndrome really starts to set in.
Which brings us to a huge, blinking red warning sign from the source literature. A progressive drop in blood pressure accompanied by a thready pulse usually signals inadequate cardiac output. When you're assessing a hypovolemic or septic patient and you feel that, it means their intravascular fluid is at a critically dangerous low. Your immediate action? You instantly bump up that IV infusion rate and get the physician on the line.
So how exactly do we stabilize a patient when they're tanking from hypovolemia? It's a fast-paced sequence. Step 1, if they lose their pulse, you are on the chest, starting CPR immediately. Step 2, get a type and cross-match for blood drawn and sent right away. Step 3, vigorously administer those prescribed IV fluids and blood products to get that vital volume back up. Step 4, put them in the modified Trendelenburg's position to help promote venous return back to the heart. And step 5, you continuously monitor their hemodynamics, their ABGs, and coagulation studies. You're trying to catch impending coagulopathies like DIC, that's disseminated intravascular coagulation, before things go past the point of no return.
Section 4. Essential Nursing Exam Takeaways.
All right, let's wrap this up with the core philosophy you need to carry into your exam and honestly onto the floor. First, you have to always identify the root cause. Is it destroyed beta cells, a blocked coronary artery, massive blood loss? Second, understand the underlying pathophysiology so you actually know why the body is failing. Don't just memorize it, understand it. Third, execute those priority protocols immediately with zero hesitation. Fourth, rely on your continuous monitoring of hemodynamics and vital signs. That's your compass for guiding the patient to safety. And finally, strict medication and fluid management is your absolute priority to prevent any iatrogenic harm. Before we sign off, I want to leave you with something to really chew on. How exactly does an untreated metabolic crisis, like DKA, eventually cascade into a massive systemic shock? Think about the massive fluid loss from all that polyuria, the resulting hypovolemia, and how those rapidly shifting electrolytes severely compromise cardiac output. Remember, in nursing, every single system is connected. Recognizing those domino effects while you're still in the golden window is exactly what saves lives. Thanks for hanging out with me on this explainer, and keep studying hard.